Hi, and welcome to the Breastfeeding Medicine Podcast. I'm your co-host, Dr. Ann Eglash. I'm a clinical professor in the Department of Family Medicine at the University of Wisconsin School of Medicine and Public Health and a board-certified lactation consultant.
And I'm your co-host, Dr. Karen Bodnar. I am a pediatric hospitalist at Inova Children's Hospital and an assistant professor of pediatrics at Virginia Commonwealth University.
I'm also a board-certified lactation consultant.
This podcast is produced by the Institute for the Advancement of Breastfeeding and Lactation Education. Hi, Karen. How are you?
I'm good, Anne. It's so good to see you.
I know, good to see you. I know, our lives are just on Zoom, and it would be so nice if we could get together and hold hands and have coffee or a glass of wine together.
I know. So this time of year is the furthest from conferences when we usually see each other. But it is nice to do video instead of just a podcast, so I get to see you. For those out there who have been listening to us for years, now we are also visible if you want to check that out.
Yes, absolutely. Yeah, what's the next best to being in a coffee shop or a bar together is doing a podcast together.
I suppose. Well, happy February. I know that it'll be later by the time this comes out, but I was excited to pick an article today that is related to the fact that in the United States, today is National Wear Red Day. And for those who do not know, this is always a Friday in February, and it's intended to bring awareness to women's heart disease. I picked Minimal Transfer of Atorvastatin and its Metabolites in Human Milk, a case series by Levi Campbell and other authors. And this was published in Breastfeeding Medicine in November of 2024. As most of you know, heart disease is the leading cause of death in women in the United States, and women also have greater cardiovascular mortality than men. Often taking statins is an important part of treating risk of cardiovascular disease, but this is frequently discouraged during breastfeeding due to theoretical concerns of disruption in infant development from drug exposure and potential nutritional changes in milk. Mm-hmm. Breastfeeding mothers requiring statins often discontinue or postpone treatment until breastfeeding cessation, which can contribute to delays in treatment of up to 14 years. This study aimed to determine the transfer of atorvastatin and its active metabolites into human milk and evaluate the infant's risk of drug exposure. This was done by analyzing milk samples from the Infant Risk Human Milk Biorepository for 3 women, and they were taking 20 milligrams, 40 milligrams, and 80 milligrams of atorvastatin daily in steady state concentrations. The concentration and its active metabolites was quantified in timed milk samples using liquid chromatography mass spectrometry. Results showed the highest absolute infant dose of atorvastatin was 0.00027 milligrams per kilogram per day. And the highest, just a teeny bit. And the highest weight adjusted relative infant dose, often called the RID, of the combined of all of the samples, the highest one was 0.9%, far below the established thresholds for infant safety.
Wait, did you say 0.9 or 0.9 or 0.09%, like less than 1%, like 9%?
Yeah, it's less than 1%.
Okay.
So 0.09%, which 10% would be sort of the established cutoff for safety for most relative infant doses, and this was less than 1%.
Great.
In addition, milk cholesterol levels were measured, and they were within previously established norms in the range of 10 milligrams per deciliter. The authors concluded that the transfer of atorvastatin and its metabolites was exceedingly low, and the impact on milk composition in states of hyperlipidemia, whether treated or untreated, is not well understood, but it is unlikely that the drug in the milk would be present at clinically significant levels, and it should not adversely affect the infant. So that was all really good news. We've really been needing more studies on statins.
Yeah,
I just wanted to
absolutely.
talk a little bit more about the clinical implications, because we have talked in the past about the changes in cholesterol during pregnancy and lactation, and I find this topic fascinating.
Me too. Yeah.
Women of reproductive age have considerably lower cardiovascular risk. However, there are many factors that can increase the risk of cardiovascular disease, though hypercholesterolemia represents the highest population-adjusted cardiovascular risk factor in women. Some of the other risk factors are polycystic ovarian syndrome, hypertensive disorders of pregnancy, gestational diabetes, and preterm delivery. The authors had highlighted some more, but I picked those actually because they're all also risk factors for low production of milk.
Oh,
And I thought it
yeah.
was really interesting when we're thinking about, the fact that we know that breastfeeding can reduce the risk of cardiovascular disease, how this is also interrelated.
Yes.
For the general population with hypercholesterolemia, the most common interventions are diet and lifestyle modification, as well as medications such as atorvastatin. And statin treatment in a large analysis has found that for every 39 milligrams per deciliter reduction in low-density lipoprotein, major adverse cardiovascular events are reduced by 20 to 25%. We know that LDL cholesterol and triglyceride concentrations rise progressively during pregnancy. The risk of cardiovascular complications due to these elevations is uncertain. And information on cholesterol and triglyceride variations in pregnant patients with familial hypercholesterolemia is limited. But in a study of 22 pregnant patients with familial hypercholesterolemia, they identified that LDL cholesterol levels and triglycerides increased significantly from baseline to gestational week 36 compared to a reference group. So not only do they have higher baseline, but they're also increasing like everyone else does when they're pregnant.
Right.
And then I think one of the key messages I have for people is that lactation plays an important role in helping women return to baseline lipid levels. Elevated triglycerides may resolve 3 times faster when breastfeeding, underscoring the benefits of breastfeeding in normalizing lipid levels. Maternal hypercholesterolemia may result in nutritional changes in milk, though this has not been well studied. There was a study of a healthy Chinese population without hypercholesterolemia that concluded cholesterol levels are highest in colostrum, decreasing in transitional milk, and lowest in mature milk. There was also variation based on the study's differing ethnicities. And a case report of a breastfeeding woman with familial homozygous hypercholesterolemia at 7 weeks postpartum found milk cholesterol concentrations 3 times higher than the control.
That's interesting.
Yeah, I mean, there's so many things about this that we only have just a case study here or a little bit of info there.
Yeah.
Women considering pregnancy or already pregnant were not adequately studied or included in the 2018 guidelines on managing blood cholesterol from the American College of Cardiology and the American Heart Association. The body of experts does not support the use of statins during pregnancy and advocates for interruptions in statin therapy when planning a pregnancy or using contraception to prevent pregnancy. A subsequent publication regarding the role of non-statin therapies, published by the American College of Cardiology, also recommends statin therapy be discontinued during conception, pregnancy, and lactation. And this all contributes to this long time that women can go without treatment. So because the statins are not currently recommended during lactation or pregnancy, because of concerns about the unknown consequences of altering lipid metabolism on neurodevelopment in infants, it has been theorized that interruption of cholesterol synthesis could disrupt the development of the brain and nervous system in developing infants. I don't know if I jotted down the statistic, but there is significantly more cholesterol in breast milk than there is in formula. And so
Yes.
we know that that plays a role in helping these babies who are growing their brains to, have higher IQs. And so
Absolutely.
cholesterol is not always a bad thing. It's a really important thing that we all need in our bodies.
Right. Absolutely. Every cell membrane.
Yeah. So there are also concerns regarding untreated hypercholesterolemia and statin interruptions around pregnancy and breastfeeding.
Hmm.
A group of researchers examined treatment delays, like I said, and found that this can be up to a 14-year delay through this period of a woman's life. So I just want to remind everyone that information suggests that breastfeeding for at least 6 months is associated with reduced maternal cardiovascular risk through reductions in blood pressure and body mass index, and in some subgroups, lower triglycerides and lower LDL cholesterol. So the authors conclude that human milk cholesterol concentrations are recorded around 9 to 15 milligrams per deciliter compared to 0 to 0.4 milligrams per deciliter in formula. And further investigation into milk and blood cholesterol levels in both treated and untreated hyperlipidemic patients would be valuable and interesting. Some other statins have limited evidence regarding transferring to breast milk. Rosuvastatin has been evaluated and has a very low relative infant dose, but there is currently no published data on simvastatin, lovastatin, fluvastatin, pitavastatin transfer into human milk. I like how I chose to give myself a tongue twister to
Yeah,
list
I
out all of
know.
these statins, which I find it really
That's a brand
challenging to say.
name. Yeah.
And though these are not routinely recommended in the peripartum period, a systemic review and meta-analysis found that pravastatin started between 12 and 20 weeks of pregnancy can reduce the risk of preeclampsia and the risk of intrauterine growth restriction, preterm birth, and neonatal intensive care unit admission in neonates. So the U.S. Food and Drug Administration requested removal of the contraindication with statin use in pregnancy, but still advises that statins should be stopped in most pregnant patients and avoided when breastfeeding. So I feel like there's really a lag between us starting to have a better understanding of the safety and actually the recommendations to patients.
Yeah, I still see people saying like, yeah, just put it off, just hold off on it until they're done breastfeeding.
Yeah. So breastfeeding has been found to lower maternal cardiovascular risk, and despite recommendations advising against the use of statin medications in the peripartum period, information suggests that breastfeeding confers significant health benefits for the mother. And the authors state the current paradox lies in the maternal cessation of breastfeeding while on statins due to a
Yeah,
theoretical risk of infant harm, while
right.
foregoing the concrete maternal and infant benefits of breastfeeding.
Yeah, interesting.
So,
Yeah, I think this is particularly timely in this generation and in future generations because I'm seeing so many people in their 40s who are becoming pregnant for the first time, they're undergoing IVF. They have established risk factors for vascular disease. They have polycystic ovarian syndrome. They have chronic hypertension that was diagnosed before pregnancy. They're already on blood pressure medications. They have high cholesterol. They're getting pregnant, and yahoo, they're having a baby. But they, number one, they're not they're not as likely to be successful with milk production. And we don't really understand like the relationship between breastfeeding and the impact on cardiovascular risk, right? Because none of these studies actually look at like intensity of breastfeeding. Like, did you supplement? Did you know how much milk were you providing for your infant? Or is it just the state of lactation, just like the fact that they're lactating and they have an elevated prolactin level? We don't know that, right? And when we look at studies of a lowered LDL in women who are breastfeeding as compared to women who are not breastfeeding, we don't know if that's related to the intensity of lactation, because the thought is like, oh yeah, they're just dumping cholesterol into the milk, and so they have lower serum cholesterol. But is it really that? We don't know. So I think that I'm glad you mentioned that, we still have this group of people who say, oh, it's okay, don't just go on and breastfeed and don't worry about the statin. But what we do want to do is definitely have them take their statin, right? Because I have seen women in their 40s have a heart attack within a year or two of giving birth. So,
yeah, absolutely. I think this really is hopefully going to be impactful when the recommendations get renewed on whether or not lactating people should take a statin if they have hyperlipidemia. Because I think that often, people get so hung up about the idea of a risk of medication. And it wasn't highlighted by these authors, but we did mention it last time we talked about this topic, that even very young children, 2-year-olds who have familial hypercholesterolemia, or sometimes even younger, will be given statins directly. And so it is, not often when I'm thinking about medication safety, I will say to parents, well, I would give that medicine directly to a child who needed it. So it's not that, getting any amount of it is bad. I also think this thing about intensity is so important, and it is hard to put into studies because collecting that data is very challenging, especially if it's not the primary thing that's being studied.
right.
And it also, to me, is really important when we think about medication safety studies, because unfortunately, when people are thinking about medication safety and they use the relative infant dose, they are assuming a baby who is fully breastfed.
Right.
And sometimes I think that rather than it being milligrams per kilogram per day, it should be milligrams per ounce.
Yes.
Now, the problem is, I have like a very high concentration of people in my practice who are doing a lot of pumping. So they know how many ounces their babies are getting.
Right.
And for people who are fully breastfed, this is much more appropriate. But it drives me bonkers when somebody is providing their baby with 3 ounces of breast milk per day and they're told to throw it away because of medication exposure. And I'm like, it's a tenth of the dose of what it would have been if they were fully breastfeeding. So It just is very sad. Those are the people who are the saddest to not give their milk. They've worked really hard to have those few ounces.
And plus, this is the population that probably is going to be the low producers as well. The other thing I'll tell medical students is that lactocytes are so incredibly smart, and they know what should not go into that milk compartment. So we have to put our faith, we have to trust that lactocytes know what they're doing. That's one thing I like to say. And then the other thing I want to say is, and I don't know this for sure, and maybe but I think in Europe, they screen pregnant women for cholesterol. And I think they treat it.
I really love this TED Talk that is by Bimla Schwartz, and you can find it if you just look up TED Talks. It's titled "How Mothers Can Nurse Themselves Healthy," and it's really about the benefits of breastfeeding on cholesterol levels.
Thank you so much. That was really interesting. I love topics about maternal health and just the role of lactation and in people's health after they give birth. All right. Well, I'm going to switch gears, but I'm going to talk about a substance as well, but this is lead. So I want to share a recently published case report of a breastfeeding mother who had an elevated lead level during pregnancy and lactation. So the first author of this case is Ashley Wallace-Wu, and the case is entitled Individualized Support for Breastfeeding in a Case of Elevated Blood Lead Levels, which was published in the journal Toxicology Reports in volume 13 in 2024. So the first thing, I just want to give you a little background about lead levels during pregnancy and lactation, because I feel like we don't pay close enough attention to this. According to a 2020 report published in the U.S. National Health and Nutrition Exam Survey, lead levels among adults in the U.S. have actually gone down from 1976 to 2016 because of less environmental exposure to lead. Even though lead exposure is generally low for Americans in the U.S., in 2020, there was an estimated 500,000 women who had high enough lead levels to harm their developing fetuses or their breastfeeding infants. Also, we know that lead is not great for pregnancy. Pregnant women with high lead levels do have a higher risk of miscarriage, gestational hypertension, and preterm delivery. And also, lead crosses the placenta and the blood-brain barrier, so fetal exposure is associated with intrauterine growth retardation, decreased postnatal growth, and unfortunately, negative neurodevelopmental outcomes. There are still several risk factors in the U.S. that increase that risk of high lead levels. So we are not scot-free in the United States. First of all, recent immigrants who were not born in the United States are at the highest risk for elevated blood lead levels. In terms of the other exposures in the United States, over 90% of the exposures come from occupational sources such as art supplies, construction sites, batteries, old cars, gun ammunition like lead shot, and eating the animals, that are shot, lead mining, and plumbing fixtures. Lead has also been found in some alternative medications, such as Ayurvedic medications, and herbs and cosmetics that are used by many cultures worldwide, and a lot of those products are available in the United States. So in the United States, it is recommended that all pregnant individuals be screened with a lead risk assessment questionnaire, asking about these various risk factors and exposures, including whether they were born outside of the USA, and then if they screen positive, they should get tested. For our listeners, you can actually just easily search the internet for lead exposure questionnaires if you're not using one. They're pretty easy to find. I found it interesting that blood lead levels can increase in the first 6 months of lactation, even without increased exposure, because lead is actually stored in bones. And with a typical 3 to 5% loss of bone density during lactation, lead ends up being mobilized out of the bones into the bloodstream. So in fact, women who are older have higher blood lead levels because of having more years of lead storage in their bones. Lead does transfer into breast milk, and according to the authors of this study, lead is one of the most likely toxic metals found in breast milk at levels above the World Health Organization suggested limit. For example, in Mexico, there was a study that was done showing that breast milk lead levels accounted for 12% of the variation in infant lead levels. And the infant lead level can climb higher over time with long-term breastfeeding because they accumulate this lead that they're taking in from the breast milk. We don't really know how much of the harm to infants is coming from lead due to fetal exposure or exposure during lactation. So I want to talk about this case. So that was a long background, but I want to talk about this case because it looked closely at her infant's blood levels. Like she stopped nursing and then she started nursing again. And so we could actually see what happened with the lead levels when it dropped and then came back up when she started nursing again. So this case is a woman from Mexico who was found to have an elevated blood lead level during pregnancy at 10 micrograms per deciliter at 15 weeks of gestation. So she was screened because she was a recent immigrant, which is appropriate. And just for reference, a blood lead level that's more than 5 is considered to be high. She was, so the source of lead for her was otherwise unclear. Like she had all the questions asked her, like, what are your other exposures? And they couldn't identify anything else other than imported foods. So it may have just been her environment when she was in Mexico. During pregnancy, because of that, the release of lead from bones, and maybe if she was anemic and ingesting lead, her blood level gradually climbed to 26 by 33 weeks gestation. So it was 10 at 15 weeks, got all the way up to 26 at 33 weeks. Her baby ended up being born at 39 weeks, and the cord lead level was 28. And on day 3, the blood lead level went up to 30. The baby's lead level went from 28 to 35, so really quickly, because of hemoconcentration. So, the baby peed like racehorse, and then the lead level went up. So after learning that her blood lead level would markedly increase after birth, she was advised to pump and was told not to give her breast milk to her baby for the first month, which she agreed to. And by 4 weeks postpartum, her lead level rose to 30. And so she was 28. The cord level was 28 at birth. Her level rose to 30 at 4 weeks. The baby's level dropped from 35 to 22 in that first month because she wasn't breastfeeding. So then it was decided the baby would start breastfeeding at 4 weeks. And by 8 weeks, the lead level rose from 22 to 28, even though mom's level was decreasing. But of course, there's still lead there, right? So the baby's ingesting this lead and the baby's level went up. So then breastfeeding was stopped again for a couple weeks. And then they went back and started nursing again. And then at that point, over time, they were able to see that mom's lead level was decreasing and so was the baby's. But the rate of decline was a lot slower for the baby due to continued exposure of lead through breast milk. So what was unique about this case is that the mother didn't breastfeed for the first month and the baby's lead level dropped, and then she started breastfeeding from 4 to 8 weeks, and then the level rose. And we don't really have a lot of data demonstrating these lead level changes, so it's a really good example of the physiology of lead level changes during lactation. And so I just want to wrap this up with some information about treatment guidelines. Breast milk levels are really hard to measure. So if you're dealing with someone who has an elevated blood level, someone who's lactating or pregnant, you're not really going to be able to get a breast milk lead level very easily. So we need to rely on the parents' lead level to predict how it will affect the breastfed infant. In fact, the CDC has a model for predicting the increase in infant blood lead levels based on the lactating parent's blood lead level. So they know from this model that when, for example, a lactating parent's level is 1 microgram per deciliter, the expected increase in the infant's lead level at 1 month is going to be 0.12. So there's this, they identify the amount of transfer. The CDC guidance is pretty clear, and they state that that breastfeeding should not be initiated when the mother's lead level is greater than 40, and that infant's lead level should be monitored closely if breastfeeding is initiated at a maternal lead level of between 20 and 39. So interesting in this case, although the cord lead level was only 28 at delivery, infant lead level was 35 on day of life 3. So based on projections from the data presented by the CDC, the infant's lead level would have been at risk nearing that chelation threshold at around 45 if she did breastfeed at the time of birth. The authors of this study mentioned that there are a few dietary interventions that individuals can take during pregnancy and lactation to lessen the rise in lead level that comes from that mobilization of bone stores of lead, which includes taking calcium and taking vitamin D, which I thought was really interesting because generally we don't think of those as really affecting bone density during pregnancy or lactation. And then also taking iron orally, which we know from pediatrics, like making sure that everyone's replete with iron and getting enough iron in their diet, that can decrease the uptake of lead from the gut. So the bottom line here is that we do need to screen people who have recently arrived to the US from other countries, particularly low-income countries, especially if they're using foods, supplements, and cosmetics from other countries. And it's a good idea to use a questionnaire to screen people. So rather than asking, just generalized questions like having pointed questions. And if the mother has high lead levels, then the infant should be monitored. And I suggest that people familiarize themselves with the CDC guidelines on managing high lead levels for mom and baby during lactation. And as far as yesterday, those guidelines were still present on the CDC website. Yeah, so I
my
feel
fingers
like,
crossed that the CDC is going to still be there for us in the future.
yeah. I think that I just think that we don't pay close enough attention. And I know that you have a very multicultural population in your practice, and you probably see a lot of women who have recently arrived to the United States.
Tons. And it's really interesting because I have not thought that much about this previously. I mean, we had a huge, push when Zika became a thing to, make sure that we were taking care of all of our
Yeah,
patients who were at risk for Zika. And
right.
it's a really
But
interesting question.
yeah, I think we need to look closer. I mean, I think we need to look at this more carefully. If I walk into like an ethnic food store in my community, you can find all kinds of products that there's no English on them. We have no idea. I don't know. I don't know what many of them are. We have groups of people, like we had a large number of people from Afghanistan who came. So we have no idea whether was there lead in pipes there? Like we don't know. I've definitely seen children who are adopted over the years who come to my practice, and upon screening, they have pretty high lead levels. So lots to learn, but I think I think the thing about the United States is we have to remember this is an international country, We have people from all over, and we need to make sure that we're aware of what's going on outside of the United States in terms of exposures to lead.
Yeah, it's a really, really interesting question because we routinely screen all of the young children for lead exposure, but I have not thought of nursing with a parent who was at risk as being one of the risk factors previously. So I'm going to have to think about that a lot more.
Yeah, we might miss it, right? So if someone weans their baby at 4 or 5 months, by the time they're screened at a year, we may not see it, or maybe it's like 10 or something, and then we think, and then we check it again and it's going down. And you're like, okay, whatever, but it could have been 40, when they were 3 months old. So.
Well, yeah, and I think the cutoff has become more strict over time as levels have
Yes.
decreased in this country, but I haven't thought that much about what is the impact of exposure. Like, we know having a really high level is bad, but having a moderately high level for a longer period of time, also bad. And is
Yes.
it more impactful in those first 3 months when the brain is growing its fastest than it is at age 2? Like trying to know more about that, I think really is important because we want to give people good recommendations. There aren't that many things that cause me to encourage people to discontinue breastfeeding because the benefits are so important. But when
Yeah.
there really are, we have to really
Yes.
weigh that balance. And
Exactly.
it's amazing that somebody would be able to wait a month and then start to breastfeed. Like most people will
Yes.
not be successful in maintaining that production.
Right. Yes. Well, that's a wrap. It was great talking to you, Karen. Thanks for,
And there was one more thing that I wanted to mention really quickly. It's
yes.
super duper short, but I wanted to
Okay.
add it on today. And it
Okay.
had to do with a letter to the editor that came out the same month, November, that I referenced in my first article. And
Uh-huh.
it was a letter that was asking us to stop using the terminology rusty pipe syndrome.
Yes. Oh, yes.
And so, for those of you who may have missed it, I just wanted to touch on that really, really quick. This was a letter to the author written by a bunch of authors, the first of whom was Katarzyna Wozolek. I'm very sorry if I have mispronounced your name. All of the authors were in Poland, and they have somewhat long and challenging names for me. But the letter was titled "Bloody Colostrum is not a rusty pipe phenomenon. Medical
Yes. Yay.
terminology should reflect accuracy and respect for the maternal body." So the authors appealed to the editor for a change in the current terminology and consider the phenomenon of visible red-brown colostrum colorization as a phenomenon of bloody colostrum or bloody colostrum syndrome. It is not a disease, does not require treatment, and resolves spontaneously. The existing term rusty pipe syndrome, which has become adopted in describing this phenomenon, is, in our opinion, at odds with current medical knowledge. According to anatomical knowledge, there are no tubes in the mammary gland, but milk ducts, and we do not find a shred of rust in human colostrum.
Very
They go
good.
on to talk a little bit more about some research that they did looking at actual erythrocyte counts in colostrum, which, if you're interested, I think people can check out. But This is definitely one of my soapbox issues. Like, it is unhelpful to say a clogged duct. It makes people think there's like
Yes.
cottage cheese stuck in there when we're usually
Right.
talking about external compression of those ducts as the milk is supposed to drain out. And I really applaud the authors for taking the time to write this. They conclude by saying, mothers need support from educated healthcare personnel. The immune cell content of colostrum and the general composition of breast milk cause even temporary cessation of breastfeeding in the case of macroscopically bloody colostrum is not recommended as a routine procedure. It should be considered as unjustified and harmful and incompatible with evidence-based medicine.
Very good. Excellent. Yes, we need more of that. We need so much more clarity in terms of what we're dealing with good medical terminology. And although I have to say that historically, so many of the things that we identify, syndromes, et cetera, have men's names to them. So maybe we can take the opportunity to call it, like the Bodnar effect.
No. I think this author, once we all learn to pronounce her name correctly, should get the credit for taking the initiative to say we need to rename this. But I also think just highlighting that it's normal. Sometimes I say to patients when I'm, describing breast milk, we're talking about like the normal development of the breast during pregnancy and all of the vascularity that develops. Like, your breast milk is very similar to the liquid parts of your blood. Like, it doesn't have all of the red blood cells. There are white blood cells from our immune system. But the reason there's such good blood supply is that your body's taking all of that and adding fat and sugar, and ta-da, it's milk.
Absolutely.
And people are just like fascinated, like, wow.
Yes. Cool.
It was really fun to talk to you. I'll look forward to next time.
Yeah, I can't wait. Yeah, I'm going to get a really good topic.
You always do.
You do too. All right, see you later.
Bye.
Bye. For questions regarding this podcast, please contact us through our website at lacted.org. We have other educational projects, including the Clinical Question of the Week, our Little Green Book of Breastfeeding Management for Physicians, and our various educational courses and conferences for physicians and other breastfeeding supporters. If you want to see what we look like, check out our Breastfeeding Medicine podcast Facebook page, where you can post any questions or comments about our podcasts. Thanks for listening, and we'll be back with you in about 4 weeks.